Sure.
Good morning, all. This week's blood culture discussion will start now. Moving on to our first case, we have a 61-year-old female who has a bicuspid aortic valve with severe aortic stenosis, for which in April 2024 she had an aortic valve replacement. She had a TTK Chitra heart valve. So when I was going through what this Chitra heart valve is, Chitra happens to be again my colleague's name, but this Chitra heart valve is India's first indigenous mechanical heart valve, which is known to be very affordable and reliable. This was introduced by Sri Chitra Tirunala Institute of Medical Sciences in Trivandrum by one Mr. Avaliathan, a cardiac surgeon who is a Padma Vibhushan and Bhushan. So we come to the constituents of this valve. Before that, we'll have a look into our case. We have a 61-year-old female with complaints of fever for 6 months, shortness of breath for 6 months. The fever is intermittent, there's evening rise in temperature, fever of more than 100 degrees Fahrenheit, there's associated myalgia and headache. Shortness of breath is grade 2 to 3 with orthopnea. Patient also has cough for 6 months. The patient is a known hypertensive. The patient has a bilateral posterior parietal and occipital region. He has an SAH in that region. In addition to that, he also has hemorrhoids. He has had a blood transfusion a year back, and she has had a hysterectomy 5 years back. So coming to the aortic valve which she has got, so this is the prosthetic valve she has got. It's actually made up of cobalt, nickel, chromium and tungsten alloy. It has ultra high molecular weight polyethylene and polyester sieving ring. It has a rotatable disc. It's manufactured in such a way it can slide in its plane. So coming to this patient, so knowing that this patient was having fever, someone outside started Septran double strength tablets, 2 tablets for 6 months. Examination, patient had pallor, clubbing and a click sound in the aortic region. This is the earlier echo finding. Patient having severe AS, mild AR, trivial MR and a concentric left ventricular hypertrophy with a ejection fraction of 53. This is the recent echo finding. You are able to see small vegetations over the prosthetic valve. In the aortic valve, there are multiple small vegetations, maximum 7 into 4 mm. It's moderate to severe AR here as well. So the point to know is that we have a patient of infective endocarditis, prosthetic valve endocarditis. Prosthetic valve endocarditis, based on how early or how late it is. If it is less than 12 months early, more than 12 months late. So in this case, that took place in April 2024. Now it is almost January 2024, more than 12 months. This will qualify as late prosthetic valve endocarditis. So the blood culture sent to us was 10th of January 2026. So we grew gram-negative bacilli. The bacilli happened to be Achromobacter xylus oxidans. This is the antimicrobial susceptibility pattern. We grew this blood culture of Achromobacter xylus oxidans in 4 blood culture bottles. The other culture samples sent were insignificant. So here we have a patient who is having a total leukocyte count of 2.28. Can anyone enumerate what can be the possible reasons in this case? Patient is having infective endocarditis.
Long-term septum.
Very good. So patient has been getting a folate antagonist for the last 6 months, so that can potentially interfere with the bone marrow production of leukocytes and cause leukopenia. Sometimes in overt infectious endocarditis, it can also cause leukopenia, especially when the vegetations tend to embolize to the spleen. Apart from that, even a sepsis-induced response, there can be leukopenia. So in this case, the ESR is elevated, so the ESR is 80, not 800. CRP 72. Procal was not that much elevated. So this patient was started on meropenem 2 gram IV TDS and gentamicin 60 mg IV 8 hourly. So what is the mistake here in this dosing?
Gentamicin.
So gentamicin is more of a concentration dependent drug. Cmax by MIC, it's a parameter. So they have followed for effective endocarditis usually 3 mg per kg of gentamicin, the empirical dosing. So this patient is 60 kg, so mounts up to 180 kg, so it has to be given once a day dosing. So for patients with prosthetic valve endocarditis, they usually start them on anticoagulants like acetone. So it prevents
this patient is in medicine or cardiology?
So this patient is in medicine.
But they normally follow the OD dosing, no?
They follow the dosing, but this patient they mentioned as EDS.
So that has to be communicated.
So such patients are started on anticoagulants like acetone. So we have to be careful in such cases because the reason for starting acetone is to prevent further thromboembolic episodes, because a prosthetic valve in itself is prone to develop thromboembolic episodes. So coming to Achromobacter xylus oxidans, infective endocarditis. Before we go into that, Achromobacter xylus oxidans, antimicrobial susceptibility testing. What are the flaws that can be encountered in infective endocarditis? This is an interesting paper in antimicrobial agents and chemotherapy from ASM. So they did a 6-year study in patients with cystic fibrosis having Achromobacter xylus oxidans. You usually read Pseudomonas aeruginosa, Burkholderia cepacia, such gram-negatives to be associated with cystic fibrosis. But here they have dealt with Achromobacter xylus oxidans. Important thing, commonality between cystic fibrosis and infectious endocarditis, anyone? Both are potent biofilm forming conditions. So studying a biofilm forming condition with respect to the pathogen involved here is something we can translate in our case, and this study was conducted in the reference center for gram negatives like Burkholderia and like other non-fermenters in Brussels. So we look at the MIC distribution of all the 267 Achromobacter xylus oxidans strains. So they have used both CLSI and UCAST cutoffs for this. This is quite a new paper released in July, published in July 2023. So here you are able to see the distribution of various antibiotics. The most effective agents against Achromobacter isolates were piperacillin tazobactam and ceftazidime-avibactam in this. If you are able to see, with 70% for piperacillin tazobactam and 62% for ceftazidime-avibactam using the UCAST breakpoints. You have to be careful using the UCAST breakpoints. So based on the CLSI breakpoints, piperacillin tazobactam was most effective again at 80%, followed by meropenem at 69%, and trimethoprim sulfamethoxazole at 61%, ceftazidime 59%, and amoxiclav 54%. So what is the difference happening here? So so the important thing is that in your UCAST group sees cotrimoxazole has a susceptibility of 3% isolates, whereas here in CLSI you have a 20-time increase, becomes 60% susceptibility. Why is this so? Because UCAST takes a strict susceptibility cutoff of less than equal to 0.125, whereas for CLSI it is less than equal to 2. So in this range you get a lot of these isolates, and cotrimoxazole comes out to be
susceptible in case of
CLSI and resistant in case of UCAST. So if you remember, even in our antimicrobial susceptibility test result, we have given a susceptibility because we are following CLSI guidelines. But if we take this cutoff, the isolate would have come out to be resistant. But anyway, we have not started the patient on cotrimoxazole. The initial therapy outside was on cotrimoxazole, and another reason is we prefer giving bactericidal agents for lesions like infective endocarditis rather than going for a bacteriostatic agent. So the important thing is this cotrimoxazole 3% was a shocker. So we have to follow UCAST guidelines when it comes to this Achromobacter, especially for cotrimoxazole. So usually it was earlier thought that cotrimoxazole is a good drug for Achromobacter, especially when you would like to de-escalate, start the oral therapy. But that is not the case when you
UCAS breakpoints, are they the wild type? They are the epidemiological cutoff because 0.125 is too less and that is too high. I mean, 2 is you can say kind of a clinical cutoff in case of UCAS. So it is possible that they might be using the ECOF and extrapolating it as a clinical breakpoint as compared to CLSI, which is probably using a clinical breakpoint. But again, CLSI does not calculate ECOF values on its own, right? It is just an extrapolating thing, whereas UCAS they have their own labs to calculate the ECOF values. So maybe yes, to be on a cautionary note, it's better to follow UCAS too.
So coming to a case report based on Achromobacter xyloscoxicans in prosthetic valve endocarditis, this is again this patient had relapsing fever, night sweats for nearly 3 months. The procedure which he underwent was a post-TAVI. He was on multiple antibiotics like meropenem, Brazil, tazobactam, and again here cotrimoxazole. So here the definitive diagnosis for prosthetic valve endocarditis was achieved via fluorescent in situ hybridization sequencing. So why I particularly inserted this case report is one which is following our case, Achromobacter xyloscoxicans with prosthetic valve endocarditis. The mode in which they have identified, they have come to a conclusion that this is the pathogen here is by an update given in our ISCVID. So the International Society for Cardiovascular Infectious Diseases in 2023 came up with an updated Duke's criteria. So initially we only used to have culture-based techniques, and lately we started following all our molecular tests. Now they are going a step further ahead and they are trying to isolate the organism from the explanted valve and the bloodstream. And they are going to tell you that this explanted valve having this organism and the organism in the bloodstream match, and it is the reason for infective endocarditis. Because sometimes PCR can pick up your skin contaminants, it will pick up organisms which are not there on your prosthetic valve, which is not on the biofilm of the prosthetic valve. So we look at what is happening here. So this is the IDSA ISCVID 2023 update on how to diagnose and treat infectious endocarditis. So what does the 2023 criteria tell us? So by culture, staining, immunological techniques, PCR, other nucleic acid based method, 16S, 18S, ITS method, sequencing, metagenomic sequencing, and finally in situ hybridization or fresh paraffin fixed tissue. So this paraffin fixed tissue, this in situ hybridization, it can be either your native valve or your prosthetic valve, which is your hardware in this case. So this is how a microorganism can be identified for infective endocarditis based on your 2023 ISCVID guidelines. So this is the paper again explaining about this fluorescent in situ hybridization model. They compared this fluorescent in situ hybridization sequencing with routine PCR. So the standard diagnostic method of PCR followed by sequencing, like out of 124 cases, they were able to find 57 positive cases. Whereas coming to this FISH sequencing, we'll see what FISH sequencing is. They were able to add up from 57, they were able to go up to 79%. That is a jump from 46% to almost 64%. So this really impacted patient care in a statistically significant way. So on the day of surgery, you get the sample. Example, you have a prosthetic valve, you get it, you fix it, then you embed it in like an embedding resin, make slices out of it, do the fluorescent in situ hybridization. You will be able to, it will have a common DNA probe, then you will be able to hybridization take place, and you will be able to see the fluorescing pattern on your slice. Again take that, so now you visually seen it. Only if that bacteria is there, it is going to fluoresce. After visually seeing, now you are extracting that same thing. You are extracting whatever nucleic acid was from that material, and now you are going to run a PCR. So now you have seen it, and you are amplified it and you run your PCR. So whatever it is there on the valve is what you are amplifying and you are finding out. So after that you go for your sequencing and then you tell this is the organism I've seen an organism on the valve. I've amplified it by PCR and I've sequenced it. So this is the workflow of your FISHseq. So as we saw, the steps will be fixation, embedding and sectioning, followed by hybridization and imaging for fish. So this slide you saw here, right? This is how your fish image will look like. So this is the heart valve tissue. In the background of necrotic, so this green color part is tissue background. This yellow color part is the pan-bacterial fish probe. This blue part is the nucleic acid. So this is how it will appear. So these are the various steps when it comes to FISHseq for infective endocarditis. Why this matters clinically? So if we get a culture negative, many a time we get culture negative endocarditis, but we get a PCR positive. Culture negative, PCR positive. In this case, it can be a contamination. So we are caught up in a dilemma. So in such cases, this FISHseq will definitely help us. It guides therapy. So example, there's active bacterial involvement, fish is positive. It needs full treatment. You'll have to completely treat the patient. But if fish is negative and PCR is positive, it does not tell you that there is active bacterial growth on that said valve or on that said heart valve. So it is likely a residual DNA from already treated infections, which is not actively there. So that can be the cause. And again, the main thing of this fish is identifying the biofilm causing agents. So PCR alone, in short, PCR alone tells you what might be there, but FISHseq tells you what is there, where it is, and whether it is actively causing disease. So this last part is important, whether it is actively causing disease. This reduces the diagnostic uncertainty and directly informs treatment strategy for our patient and especially the duration of treatment. So in this case, first case, like even non-fermenting gram-negative bacteria can cause infective endocarditis. We have to look for various risk factors for that, patient factors, environmental factors. All those things have to be looked at. Important takeaway is not to use cotrimoxazole for infective endocarditis with respect to this Achromobacter, and the use of a new modality of FISHseq when it comes to especially hardware based your prosthetic valves for infective endocarditis. Now coming to our second case, we have a 40-year-old male. Again, we are sticking with infective endocarditis for this case also. Case of a mitral valve prolapse with severe mitral regurgitation for the past 9 months. Fever for 5 months, high grade intermittent, evening rise associated with chills, rigor, decreases with intake of paracetamol. Patient also has cough with sputum production for 5 months. Patient also has shortness of breath on MMRC grade 2. There's loss of appetite and loss of weight. He's lost 15 kgs in the last 6 months. There's blurring of vision. He's hypertensive for the last 5 months. So, what are you able to see here in this picture? It's not very clear, but there are pointers. Infective endocarditis, such a oral cavity. Patient is having dental caries, right? So, potential source for that lesion in the heart, a potential reason for that organism in the blood. So the patient has pallor, there are dental caries, and S3 is heard, there's S2 wide split, there's a pansystolic nerve heard at the apex, PSM is heard at the apex. On fundoscopy, you are able to see both the grade 2 hypertensive retinopathy. We saw the patient is already hypertensive. On 2D echo, we are able to see a hyperechoic independently mobile mass present on the prolapsed posterior mitral leaflet. There is severe MR in this case, ejection fraction is maintained. So coming to our blood isolate. So for this patient, sample was sent on the 13th of this month. We saw gram-positive cocci in short and long chains. The organism isolated is Streptococcus gallolaticus, subspecies gallolaticus, identified by audit of MS. If you remember in our last week's culture presentation, we had a similar organism and a similar presentation in a female, different patient altogether.
This is the second case.
This is the second case. This is not the same patient, sir. Second case. This is a male patient whom we have isolated Streptococcus galloperaticus subspecies galloperaticus. So what is the usual source of Streptococcus galloperaticus? It's a commensal bacterium. It can be in the oral cavity. It can also be in the colon as well. Yeah. So it is more of an opportunistic pathogen, right? Yeah. So in this case, ampicillin susceptible, doxycycline susceptible, high level gentamicin synergy is there. Chloramphenicol, erythromycin, penicillin G we have given here as susceptible. I'll also show the crude White report. It bears role when it comes to treatment. So there's one episode of bleeding PR 9 months back in this patient, 2 ml. When PR examination was done, there was no mass lesion. The gloves didn't have any bleeding. There's no external hemorrhoids, no fistula, fissure, skin tag. So why is this important in this case? Streptococcus galloperaticus.
Last case also there was adenocarcinoma, some.
So it has some association with colorectal carcinoma, adenocarcinoma. Some species also have relationship with the hepatopancreatic biliary cancers. So this association has to be kept in mind. So Streptococcus galloperaticus, infective endocarditis, bacteremia, and this association with colorectal carcinoma. So if you look at this patient's total leukocyte count, it is mildly elevated. You are able to see CRP is elevated, ESR is elevated, procal is relatively normal. Patient is 51 kgs because he has lost almost 15 kgs over the last 6 months, right? So here they have started him on ceftriaxone 1 gram IV 12th hourly and injection gentamicin 150 mg once a day IV. So here they followed the proper 3 mg per kg OD dosing. Patient was also on metoprolol, torsemide plus spironolactone, paracetamol and pantoprazole. So the important thing to note here is, you look at the patient's hemoglobin. Any male with severe anemia is always considered, they usually say in surgery, bleeding PR, patient with severe anemia, in a male patient is always considered to have some sort of gastric or adenocarcinoma unless proved otherwise.
Normally gentamicin dose is 5 mg per kg body weight, right?
So in the ESC guidelines they have given us 3 mg per kg. OD. 3 mg per kg per day, sir. That guidelines also we will be discussing. So in this patient there is severe anemia. So they are evaluating that for this patient. So in colorectal carcinoma, the lab findings often reflect an iron deficiency anemia from the chronic blood loss. In this patient, the stool occult blood was negative. Again, the peripheral smear showed microcytic hypochromic anemia with mild leukocytosis. So the microcytic hypochromic tells us again there is some iron deficiency anemia. Mild leukocytosis tells us there is some sort of systemic infection happening here. So there is also elevated ferritin, there is low serum iron and decreased DIBC. The high ferritin in this case can be because of advanced metastatic disease also. We are not sure of that. So an ultrasound abdomen done for this patient didn't show any lesions in the colon. So there is only mild right pleural effusion, which is not significant. So the problem with ultrasound is when it comes to detecting colonic lesions, it can be used. Certain studies say that it can be used as a decent screening tool, but the problem is ultrasound colonography can depict the distal sigmoid colon and rectum with good visibility. It is capable of detecting distal sigmoid and rectal neoplasms of more than 10 mm in diameter. It has good sensitivity and specificity. So a better investigation which we have to recommend in this patient would be, we will have to suggest a colonoscopy. Okay. So coming to the recommendations of empirical antibiotics in a patient having late prosthetic valve endocarditis. Late prosthetic valve endocarditis, we saw more than 12 months after surgery, right? So here they say ampicillin in combination with ceftriaxone or with flucloxacin and gentamicin should be considered. So here we saw patient is receiving ceftriaxone plus gentamicin in this case. Ceftriaxone 4 mg per kg, 2 dose patient was seeing that, and gentamicin 3 mg per kg here. So if it is prosthetic valve endocarditis which is early, less than 12 months, was associated with nosocomial or other healthcare associated infective endocarditis, they are asking us to add vancomycin or daptomycin combined with gentamicin and rifampicin. So what is the rationale here? They are trying to cover an MRSA. They are trying to give an MRSA cover with gentamicin, a gram negative cover. And why is this rifampicin added here? It is for an anti-biofilm property of rifampicin, because again prosthetic valve biofilms will be formed. So again these are the dosing regimen for these agents. So coming to our crude White HT report, here it says the penicillin interpretation as intermediate or susceptible to increased doses. That's what we say, right? So here it is intermediate. Erythromycin is resistant, remaining all are susceptible. So again we will go to the guideline, the same document, ESC guideline. They have a separate division for if it is penicillin susceptible, Streptococcus galolyticus, if it is penicillin intermediate or penicillin resistant, Streptococcus galolyticus. So for penicillin intermediate or resistant Streptococcus galolyticus, that same document tells us that these intermediate and resistant strains are accounting for more than 30% of strains now. So they are asking us to give penicillin, amoxicillin or ceftriaxone for 4 weeks. So you are going to give a beta-lactam agent for 4 weeks in this case. With gentamicin, 2 weeks is recommended following. They are asking us to give a combination. So the same here, we have already followed it. Ceftriaxone patient has received along with gentamicin. So we have to make sure that it is 4 weeks plus 2 weeks. It is not 4 plus 4. And if it is already penicillin susceptible, no, if we give only the beta-lactam agent for 4 weeks, that is more than sufficient. You needn't add the gentamicin in this case. So we had a lot of discussion regarding Streptococcus galolyticus, how it's closely related to Streptococcus mutans. All. So it is a catalase negative organism. It usually has non-beta hemolytic colonies, gram-positive cocci. It has undergone a lot of taxonomic variations, a lot of reclassifications. So initially it was called equinus, then it was called bovis. Now the initially called Streptococcus capitis is called Streptococcus galolyticus. So this galolyticus again it was divided into biotype 1, 2 by 1, 2 by 2. So now we all divided into galolyticus, subspecies galolyticus, infantarius, subspecies infantarius, galolyticus, subspecies pasteurianus, and so on. So these 7 are the important species and subspecies. So again, coming to our identification systems, we have Vitek in our lab for identification and AST. We have a Malditov from Biomeru, also Vitek MS. So these are the various systems, how they fare against all these streptococcal bovis group agents. Okay. So here our area of concern will be this Vitek 2 and this Vitek MS Malditov. So they have also done 16S rRNA sequencing, they have done superoxide dismutase sequencing, all that they have done and they have compared in this review. So coming to a case report again here, we have a Streptococcus galolyticus endocarditis. Again this patient has colonic cancer. You are able to see this patient is an 81-year-old male with mechanical aortic valve and pacemaker, and he developed a device-related endocarditis. Patient will have a pacemaker. There will be a ventricular lead attached to it. So in this ventricular lead, they were able to isolate this Streptococcus galolyticus. So this part you are able to see. So there is a large vegetation attached to the ventricular lead, and this is the colonoscopic picture. You are able to see a large 3 by 2 centimeter pedunculated polyp with a 4 centimeter stalk in the sigmoid colon. Patients having SGG bacteria and endocarditis with a lesion in the colon. So, how are we going to why does this Streptococcus galolyticus subspecies galolyticus cause cancer? We have to look at that, right? So there are two stages. It is a passenger at one stage, it's a driver at another stage. When is it a passenger, when is it a driver? So SGG acts as a passenger bacteria. In pre-neoplastic epithelium, activation of WNT pathway. So these pathways are associated with development of neoplasia, leads to downregulation of bile transporter. So the specific bile transporter associated here is SLC10A2. So this results in accumulation of bile acids, which in turn activates a specific bacteriocin. So this enables the Streptococcus galolyticus subspecies galolyticus to kill all the related common cells. It can be an enterococcus for that matter. So this local microbial imbalance leads to a pre-neoplastic epithelium in that area. So next, it is just being a passenger. Now it is becoming the driver which is going to cause carcinogenesis. So there is high colonization of Streptococcus galolyticus in this pre-malignant epithelium. We saw that these bile acids aren't going to get they are going to get accumulated there. So what is going to happen here? They are going to induce a specific inflammatory response in the form of IL-1, COX-2 and IL-8. This is going to increase the proliferation with upregulation of another pathway, which is your beta-catenin levels and its oncogenic downstream target like CMYC and D-cycling. So here you are able to see all these factors are going to increase. So this is going to increase your cell proliferation. And this is how from a pre-malignant neoplastic epithelium, it is going to pre-neoplastic epithelium, it is going to form a malignant epithelium. So within Streptococcus galolyticus subspecies galolyticus, there are a lot of strains. They said irrespective of whatever strain it is, if it is isolated, you have to rule out Streptococcus, you have to rule out colorectal cancers with this paper. This paper was released in September 2025, again in ASM. Again, this is Streptococcus galolyticus, but it is not subspecies galolyticus. It is Streptococcus galolyticus infantarius. So this infantarius species, they have not found its association with colorectal carcinoma. So in this case, he has reported saying that we were deciding as to whether to do a colonoscopy or not. Since it was not associated, we didn't do colonoscopy and it turned out to be okay. So that is with respect to this case. So now we come to an end of our second case. So our second case important takeaways will be, the main thing is whenever Streptococcus galolyticus comes, because they, depending on the studies, they say almost 40 to 70% association is there. A rough figure. So colorectal carcinoma, colonoscopy has to be suggested, and whenever we see intermediate or resistant penicillin isolates, we have to add gentamicin to our beta-lactam like ceftriaxone. So moving over to our next case, we have a 50-year-old male who has 8 days of fever, intermittent, 2 episodes per day, lived on taking paracetamol. He also has right loin pain for 4 days, continuous severe radiating to the front of abdomen, this generalized weakness, chills and rigor, this decreased urine output for 2 days. So with this history, you know where it's going, right? It's going more towards a pyelonephritis like picture. Patient has passed blood in his urine, 2 episodes 2 days back. He has also had vomiting, which is 2 episodes non-bilious, not associated with blood. In the ER itself, he had a paroxysmal atrial fibrillation. It reverted back to a sinus rhythm itself. So this is just one episode, keep it in mind. That atrial fibrillation, we'll have a look at the ECG, how fast ventricular rate it had. So here we have a picture of right-sided pyelonephritis possible AKI with mods if you look at the other parameters. So on 12th of January, the blood culture was sent. Gram stain showed gram-negative bacilli, they grew Escherichia coli. So this isolate was a possible ESBL plus AMC producer. So we had suggested meropenem. In this case, amikacin was also suggested as a carbapenem sparing option to be given along with meropenem, even though amikacin was resistant. So in our last class, we saw it initially during our first 48-hour period, adding aminoglycoside to a patient having pyelonephritis. It is not going to worsen the AKI. The creatinine levels are going to fall irrespective of whether you give an aminoglycoside or not. So continuing with this case, so we are able to see the CBC of this patient. The TLC is normal, but the neutrophils are elevated. You are able to see pus cells in the urine. Again, the important thing to note in the CBC is that the platelet counts are drastically decreased. It's only 58,000. So again, the peripheral smear is showing normocytic normochromic anemia with thrombocytopenia. The urine culture sent twice showed no growth. So can it be no growth still in urine and still be pyelonephritis? Yes, it can be. CRP was elevated, procalcitonin was elevated. The patient's pro-BNP is also elevated. So patient has to be evaluated for conditions like heart failure or other conditions like cardiomyopathy leading to heart failure. The drop levels were okay. You are able to see the pattern in which the AKI has decreased the blood urea and the serum creatinine from the day the blood culture was sent. It was blood urea of 167 and serum creatinine of 4.2. Creatinine has drastically dropped from 4.2 to 1.5 in a matter of 4 days. So this means that AKI is resolving. Patient also had mild hypokalemia, 3.2. From 3.2 it became 4.2. That is not 34. So it's a typing error. From 3.2 it went to 4.5 with potassium chloride correction. So the patient showed a typical compensated metabolic acidosis picture. The patient's liver enzymes were also elevated. This is part of the mods the patient had. Patient was started on injection meropenem 1 gram IV 8 hourly. As a result of that atrial fibrillation, patient was started on metoprolol beta blocker and he was given other supportive treatment for his liver, for the hypokalemia and for the fever and vomiting. So this is the NCCT KUB of the patient. So you are able to see mild perinephric fat stranding. You are able to see here. Mild areas you are able to see here, right? Mild perinephric fat stranding and renal facial thickening. So this says imaging wise there is a possibility of acute pyelonephritis. So in the CT done outside, they also commented on cystitis and the patient having right hydronephritis. They also said there was a non-obstructive renal calculate in the renal pelvis. So all these factors lead to the patient developing pyelonephritis. So this is the ECG at presentation in the ER where the patient had atrial fibrillation with rapid ventricular response. We usually take the distance between two RR intervals, count the number of big boxes between them and divide it by 300, right, usually. So normally it should come less than 100 pulse rate, 60 to 100. So here if you take 300, you are getting only less than 2 big boxes you are getting. So 300 divided by 2 or 300 divided by 1.5, so your range will come between, your pulse rate will be between 150 to 180 almost. So patient is having atrial fibrillation and there are also non-specific ST and T wave abnormalities noted in this patient. So after some time the patient reverted to normal sinus rhythm. So here we have an again interesting case report with similar findings. What we should think of? Patient is having flank pain, you are suspecting it can be pyelonephritis, it can be anything else. Patient is also having atrial fibrillation. How should you follow up your investigation? What does atrial fibrillation do? If there is an emboli, if there is a thrombus, it will throw emboli throughout the body, right? So if patient is developing flank pain, more flank pain after an atrial fibrillation episode, you should think of a vascular cause. So in this case, you should think of a renal infarction. So you should. So here we have a 49-year-old male patient with no prior history presented with palpitations and right flank pain. So again the ECG showed atrial fibrillation. The important investigation here will be as abdominal CT angiography showed focal renal infarction. So this is a result of the thromboembolic episode from the atrial fibrillation. So this can also lead to macroscopic hematuria. This patient again resolves spontaneously. So you have to look at this vascular cause of AF whenever you have a thromboembolic episode. Again here it was managed with the beta blocker similar to our case. So we saw some of our CT images. What if it is an emphysematous pyelonephritis? So what agent usually causes emphysematous pyelonephritis? Any gas producing organism, like any organism which produces more gas? Klebsiella. Like this is how you convert your lab data to clinical data. In lab, in our tubes, we see gas is produced more. So if it is there in that closed area, it is going to produce more gas. So again, we have a classification for emphysematous pyelonephritis. Why this is important? Because this is going to decide our antibiotic, whether our antibiotics are going to work or not. This is Huang-Seng classification of emphysematous pyelonephritis. So if it is usually within stage 1 and 2, just antibiotics with percutaneous drainage, percutaneous nephrostomy is going to help. For the higher grades, you may have to go for a surgical approach. So your understanding of what is perirenal and pararenal is important. So here we have a class 1, which is this black part is the air. You are able to see air in the renal pelvis. So renal pelvis is the collecting system, right? So this is grade 1. So antibiotic plus drainage will do. Coming to grade 2. This is from the collecting system, it has gone to the parenchyma. So here you see the whole parenchyma is involved, not just the collecting part. The collecting part is the medial part, right? So here the whole parenchyma is involved. So again here antibiotics plus percutaneous nephrostomy is going to help you. 3A. So now it has gone into the perirenal space. So here you see this is the perirenal space. This green area, no? This is the perirenal space. It has not breached the renal fascia, right? So if you remember renal fascia, we call it Gerota's fascia, right? Anatomy. So it does not breach that fascia yet. So coming to 3B. 3B is when it is going to extend beyond the Gerota's fascia. Here you are able to see that the fascia is still maintained. Here you see that the fascia is disrupted. Now it has gone from perirenal to pararenal. Finally here grade class 4 you have bilateral parenchymal gas changes. So for 3A, 3B and 4 surgical approach gives better results. So our isolate was a AIIMS producing Escherichia coli. So which pathotype of E. coli is important when it comes to UTA? UPEC, right? Uropathogenic E. coli. So these are the various important virulence factors: the fimbrial adhesins, the curly non-adhescent protein, iron scavenging system, the siderophores, the various secreted toxins. So these fimbria are going to help in adhesion. The main mechanism by which it is going to stay there inside the renal system or the urinary bladder is again going to form an intracellular community, not just extracellular. It is going to go inside. How is this formed? It's going to form intracellular bacterial communities and quiescent intracellular reservoirs. So this is going to protect from the immune response. Then it is going to produce toxins like hemolysin, CNF1. It is going to have a lot of iron acquisition. It is going to help in its nutrition. So that is done with the help of siderophores. Then again it is going to evade the immune system by biofilm formation and modifications in its LPSO antigen and phase variation of fimbria. So these are the various strategies of uropathogenic E. coli which is leading to persistence. So you see a lot of patients, especially immunocompromised patients, they repeatedly getting E. coli. We have a patient in our OPD, SLE nephrite, a lupus nephritis patient. For the last 2 months, she's not having any lower UTI symptoms, but she's not having any fever. She's treated with phosphomycin. Continuously, she's been getting isolation of E. coli. So these can be the various molecular mechanisms by which that can happen. So So apart from antibiotics, what are the various things that can be explored? There is phage therapy, there are vaccines which are subunit and peptide based vaccines for UPEC, especially looking at the iron siderophore acquisition part. So this will induce a protective immune response. Immunomodulatory agents, so agents inhibiting interleukin 1 beta. So this is going to enhance clearance and reduce inflammation. Certain small molecules like pylicides and curlicides. So the pili and fimbriae and curli, so what is going to go and attach to the human cell. So inhibiting these virulence factors is going to prevent the formation of biofilm, going to prevent persistence. Again, we use nano formulations like how we have liposomal amphotericin. So other nano formulations where antibiotic is concentrated well and it can overcome the biofilm activity and efflux activity. Such agents can be tried. And quorum sensing inhibitors. So biofilm is all about quorum sensing. So agents which can inhibit the communication between these agents, these bacteria, can be looked into. Coming to our case 4. So the bloodstream of this patient, we've isolated Candida auris 2 times in this episode, totally 3 times. So this is an acute hemorrhage patient, 47-year-old male with acute hemorrhagic stroke, capsular ganglionic bleed. Patient has pulmonary thromboembolism, thrombectomy has been done, he has multiple systemic arterial thrombi. He's a hypertensive. He's been in and out of the ICU for the last 1.5 months to 2 months. There are multiple MDROs isolated from this patient over a period of 45 to 50 days. So these are the various organisms we've got over the last, say, 45 to 55 days. Staphylococcus epidermidis, Emphysematous aeruginosa, Candida auris, Carpinum resistant Klebsiella pneumoniae, Carpinum resistant Acinetobacter baumannii, Stenotrophomonas maltophilia, again Pseudomonas aeruginosa from urine, and the patient has a big gaping bed sore, almost grade 3 bed sore on his back, and swab from that also to prove mixed flora. So this Candida auris, 10 days back, if I am not wrong, recent 2 blood cultures, only 1 culture grew positive for Candida auris. He wasn't started on any antifungals. Now on the repeat blood culture, both the bottles grew Candida auris, and now they've started caspofungin 70 mg OD loading dose followed by 50 mg maintenance dose OD. So these are the various antibiotics that the patient has received prior to starting caspofungin. He's got ceftriaxone, metronidazole, clindamycin, colistin, ampicillin, minocycline, levofloxacin, ceftazidime-avibactam, aztreonam, meropenem, and teicoplanin. So we saw patient had CRAB. So this colistin, ampicillin, minocycline you have got for CRAB. For Carpinum resistant Klebsiella pneumoniae, you have got this ceftazidime-avibactam, aztreonam combination. He got Stenotrophomonas also once from the secretions. So in the DT aspirate Stenotrophomonas, you would have got levofloxacin. For the Pseudomonas aeruginosa AMC, you would have got meropenem. They would have given gram-positive coverage in the form of teicoplanin. This they would have started empirically before cultures. So all these agents he has received. So ideally such patients we have to evaluate for antibiotic associated diarrhea. So there is a scoring system. Since we are into prescription auditing, there is a scoring system or a criteria called Gyssens criteria which looks at rational antibiotic use, especially for patients who are going to have a longer ICU stay. So in our hospital, if we say patients with such cerebrovascular accidents, they are bound to their bed, they have a lot of multiple comorbidities, they are prone to develop more infections. So from a prescription auditing point of view, how can we streamline this? So this Gyssens score is nothing but a systematic qualitative audit tool used to evaluate the appropriateness of antibiotic prescriptions in clinical setting. It classifies antibiotic use into categories based on predefined rational criteria. So these are the various categories. You have 0, 1, 2A, 2B, 3A, 3B, 4A, 4B, 5 and 6. So this is the description. So if Gyssens category is 0, it means it is rational. So in this study, only 33.3% of the patients have got a rational antibiotic coverage. That's 10 out of 30. Remaining 66%, they have not. That is irrational use. So again, this is the same. So category 1 says delayed start stop. Category 2A says dose too high. Category 2B says dose too low. Category 3A says duration too long. 3B says duration too short. Category 4A says spectrum too broad. Category 4B says spectrum too narrow. Category 5 says no indication. Category 6 says incomplete data. So in a hospital we see some surgical units following Brazil tazobactam plus metronidazole. So what category does this fall into? Redundant antibiotics. So it can either fall into category 4A or category 5. 4A as in spectrum too broad. You are giving redundant antibiotics, or there is no indication to give extra metronidazole. You are not facing an amoebic liver abscess or any other parasitic indication. So in such cases you can make out this Gyssens classification. So in this study they looked, the IV to oral switch was poor in the CVA patients. They also noted that ceftriaxone was the most commonly used agent here, and this Gyssens criteria can be used as an important tool for a rational antibiotic use when it comes to our prescription audit. Thank you.